I'm going to go ahead and start with the basic exam for the cervical spine for case number 4. And it's similar to what I did for the case 1, 2, and 3 for the lumbar spine. And what we're going to look at is trying to quickly get the most amount of information with the least amount of testing. And also, for the cervical spine, the emphasis on differential diagnosis is a little bit greater. There's a little bit more pathology related to what we just talked about in terms of the presence of the spinal cord. And so the examination is going to begin with looking at range of motion to determine whether or not the patient has any limitations, and in particular the capsular pattern limitation. The capsular pattern limitation for the cervical spine is extension most limited with mild and equal limits of side bending and flexion. So what I'll do is I'll guide my patient through flexion first, looking down. What I also want to do is observe the cervical lordosis. Then the next thing that I'll do is I'll have him look up at the ceiling, and I'll guide him through these motions. Okay? Then what I can do is I can come around and guide him through extension with retraction. And what I'll do is I'll just use my hand here along his occiput. And then what I'll do is I'll then press your chin in, and then I'll add the retraction with extension at the same time. So I'll do that as a active assisted motion. Then I can go in with my side bending and rotation. And what I can do with side bending is I'm going to start off with side bending to the right, looking at the amount of motion and whether or not this provokes symptoms or not. And for some people, when they have tight upper traps, I can have the patient shrug their shoulder up on that side, and so that gives me an idea of how much their cervical side bending range of motion truly is without the upper traps. And I can do the same thing going in the opposite direction towards the left. Okay, and then shrug your shoulder up, and then I can go ahead and see if you can go a little bit further. And generally that's the case. When you shrug the shoulder up, the patient can side bend a little bit further. Next thing that I'm going to do is look at rotation. So, and looking over your right shoulder, so I can look at that actively and see how much motion he has and whether or not that produces any symptoms, and I can have him look to his left. Then what I want to do is I want to take him out and see what his passive range of motion looks like, and so I can stabilize his shoulders with my elbow on the dorsal aspect of his right shoulder, and then on the ventral aspect of his left shoulder, so that way that prevents him from his trunk from rotating as I take him to his full in range of motion of rotation, and I can get a better idea of how much passive rotation range of motion he has. And I'm just going to switch my elbow placement again. So ventral on the right side, dorsal on the left side in order to stabilize the trunk, and then I'm going to bring him all the way into full rotation to the left. Okay. I'm going to go ahead and continue with the examination and look at deep tendon reflexes. I can look at the biceps reflex. What I do is I place my thumb over the tendon and I give him a good whack with it. And usually what I do is I try to repeat this 3 to 4 times just so I can make sure that it's a nice, strong reflex. I'll go ahead and bring him into neutral supination and pronation, and then I'm going to test his brachioradialis reflex. And what I'm going to do is I'm just going to tap the distal end of the radial aspect of the radius, and then I see a little twitch, and I'll repeat that 3 to 4 times. Then I'll go ahead and look at his triceps reflex, in which case I'll just usually try to let him relax with the arm at the side, and then I'll just give the triceps whack, and you can see a little twitch response. I will do this test bilaterally and look at a comparison from side to side. I'm going to go ahead and continue with deep tendon reflexes. I'm going to look at the patella. There we go. So I usually repeat it a few times to make sure I get a nice brisk response. What can happen sometimes if you hit the wrong spot, then you might not get a response at all. It's not hyporeflexia, it's just because I missed the patella. And so I give it I'm missing a lot. So I'll go and do the same thing on the opposite side. There we go. Normal response, and I can come down and look at the Achilles tendon. And what I do is I put the gastrosoleus on a little bit of a stretch by dorsiflexing the ankle. I can do that on both sides. Okay. The other test that's really important in the cervical spine is the Huffman's test. The Huffman's test is a test for upper motor neuron. And so what I'm going to look for is an abnormal response, which would be as I provide some noxious stimuli to the middle finger, the tip of the middle finger, by flicking it. What I look for is a twitch response of the thumb. And so a normal person will not have that response. And so what I look for is a twitch of the thumb, which would indicate some type of upper motor neuron issue. The other thing that I can look at is the Babinski test, which I'll also do for the lumbar spine, but again, here it becomes particularly important because of the presence of the spinal cord. And what I'm going to do is I'm going to bring my reflex hammer along the plantar surface of the foot and then across the metatarsal heads from a lateral to medial direction. So again, that way with a positive response or pathological response would be extension and splaying of the toes when I perform the Babinski test. So let's set up. One more test that I can do to look at a screen for neurological function is the scapulohumeral reflex, which looks at C1 through C4, and I have two spots that I can hit looking for hyperreflexic response. And so the first spot that I can hit is right here on the cranial aspect of the spine of the scapula, and I can just give a little tap there. A pathological response or a hyperreflexic response would be a shrug of the shoulder in that direction. The other spot that I can hit is on the lateral border of the acromion here, and I can tap that spot. And a hyperreflexic or pathological response would be a abduction of the humor. So it's really important to make sure that the arm is sitting in a resting position to allow that response to occur. Okay, the final aspect of the examination is to look at a quick screen of the myotomes, and I'm going to start off with C1, C2, and that's resisted cervical flexion. And what I can do is just tell him to gently press your forehead into my hand, and I can hold that and then relax, and it's trying to be careful to make sure it's a nice isometric contraction. I'm going to do the same thing with cervical side bending for C3. I'm going to have him side bend to his right, again making sure it's a nice easy isometric contraction, and relax. And then I'm going to do the same thing over here. Just slowly build up your pressure and push into my hand. Push, 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 and relax. So it's important, especially with the cervical resisted test, to be very gentle and make sure that they increase their pressure gradually, so that way they don't get discomfort just from performing the isometric test, because what you're really looking for is actual weakness in this area. So looking at C4 is going to be shoulder girdle elevation, so you're going to raise your shoulders up like that. It's going to relax down, and then push up into my hands. Push, 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 and relax. Then I can go at C5, and I got a couple of options for C5. I have shoulder abduction and external rotation of the shoulder, so I'll look at abduction first, so then push out against me, push, push, push. There's my isometric for abduction. I'll come around here, and I'll do the same thing with isometric abduction to the left, push, push, push. And then I can also look at external rotation, letting the elbow bend, keep your elbow right at your side like that. And I'm making sure that I use my opposite hand to go ahead and stabilize this trunk, and now I'm going to go ahead and push out, and push, 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 and relax. So a nice isometric contraction. I'll do the same thing on the opposite side. Keep your elbow on your side, slowly build up your pressure, push, 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 and relax. C5 for shoulder abduction and external rotation. I can look at C6, which will be elbow flexion as well as wrist extension. So again, push up against me, elbow flexion, good. We're going to do the same thing on the opposite side. And push up and relax. And then wrist extension for C6. So and push back and relax. I'll do the same thing on the left. So push back, good. And then finally C7 is resisted elbow extension and wrist flexion. So push down push down. And relax. And then wrist flexion, the final test that we'll do for C6. I'm sorry, for C7. And go ahead and push down. Relax. And push down. The C8 myotone, I can look at resisted thumb abduction, so push back against me here. And C8 on the left, push your thumb back. And for T1, I can have him squeeze your finger, hold your fingers out like that, squeeze them together as tight as you can. Don't let me pull them apart. Don't let me pull them apart. Good. Don't let me pull them apart. For T1, and same thing on this side. Squeeze them together. Good. And squeeze them together. Good. Okay, the final aspect of the neurological screen is a quick test for dermatomes, and I'm going to follow the dermatomes as outlined in your slides. I can look at C5, and what I'll do is I'll do light touch. And my question to the patient is, does this feel the same on either side? So I'll do light touch on the left, and I'll do light touch on the right. Does that feel the same? So it's a yes/no question. And I can go down to C6 at the thumb, and I can touch lightly, and the same question. Does that feel the same on either side? And what I always try to do is I try to make sure I can find something that will really assess light touch. And I will not use my finger because that's a little bit different sensation. Sometimes that's more of a pressure sensation than a true light touch sensation. So after C6, I'll go to C7 for the tip of the middle finger and touch lightly. And touch lightly. Does that feel the same? Same thing. And I go to C8 for the ulnar aspect of the fifth finger, light touch on either side. Medial forearm for T1, touch and touch. And then the upper medial forearm for T2. So I can touch here and then touch here. Good.